Okay, this is Chapter 19, Part 3. We're moving on to autism. I'm used to autism being called pervasive developmental disorder, PDD. Your book calls it autism spectrum disorders. Either term I think is pretty well accepted though. And it's a complex developmental disorder of brain function. There's a broad range of and different severities of intellectual as well as behavioral deficits that go with this. It does manifest between 24 and 48 months, and your book says it occurs in 1 out of 166 children. I believe that number has changed since the book was published. I believe it's 1 out of, it's like 110 now, 106, 110, something like that. It is more common in boys than in girls. Etiology. Well, it's recognized as a genetic disorder of prenatal and also postnatal brain development. So it can kind of be caused anywhere along between fetal development and after birth. There seems to be immune and environmental factors involved. Certain viral infections seem to be more closely associated with it. We do know there's a genetic susceptibility, but it's not really understood very well. There may be a possible autosomal recessive inheritance because of increase that we see in twins, but again, we haven't been able to find it on a gene. We really don't know how that works. There's no gene identified. There was a thought for a while that it could be related to vaccines, and the preservative used in vaccines, it's mercury based. That's pretty well been disproven. They've taken that preservative out of vaccines except for the flu vaccine, but children are exposed to so little of that anymore, and we've still seen an increase in our rates of autism. And so what do we see? What are the clinical manifestations? We see some peculiar characteristics in these kids. Their social interactions are not normal, their communication is not normal, and they have odd behaviors. They do a lot of self-stimulation where they'll flap their arms or bang their head, that sort of thing. They don't do eye contact, and that's usually one of those early signs we're looking for. Children who don't make normal amounts of eye contact or seem to avoid eye contact. At least half, 50 to 70%, will have some degree of cognitive impairment as well. There are a small percent of individuals with autism who are called autistic savants, which means they're exceptional. They're brilliant in one area. It might be music, art, math, whatever, but overall their social skills are abnormal and they tend to be fixated on that one thing. And that's one of those the odd behaviors that they do. They tend to perseverate, which is to focus exclusively, unable to transition away from it on one thing. And it might be something like vacuum cleaners, and they will know every brand and every component to make a vacuum cleaner work, or washing machines, or cars, or but it's not just normal interested in a topic. It's to the exclusion of everything else. It's just unusual. Speech and language delays are common, and when we're looking at the whole spectrum, we can say that they're common. When you're talking about true autism, speech delay is one of the components of that. If you're talking about Asperger's or your milder forms, then you don't necessarily have the language delays. Prognosis. Most of these kids with autism, it's severely disabling. They're not going to be able to really live independently and care for themselves. So some children will improve, And particularly if we can get language skills. As long as they can learn to speak, they do better. The children who never develop verbal communication, obviously that's more disabling. And yeah, most will require some lifelong adult supervision. Other psychiatric symptoms occur frequently during adolescence. About half of the children will develop other psychiatric symptoms during adolescence. So some nursing considerations. These kids need structure. They need structure, and they need intensive behavioral modification programs. They struggle with transitioning from one thing to the next. They throw tantrums. They run away. They don't really respond to verbal. You can offer them candy and you can tell them no. They don't respond to verbal. It's not selective hearing. So we need to be very structured and have ways that we can make sure their behaviors are safe. So care during hospitalizations, we really want the parents to stay as much as possible. Again, we don't want parents to feel guilty if they can't. They may have other children, they may live out of town, and these kids are hard to raise. They may just need to go home and have a break. And we don't want them to feel guilty if they need that, but if it's possible, we want them to stay because they know this kid and we don't. We want to decrease stimulation. Many of them, hyperactivity is one of the other problems that they'll also have. They tend to have hyper responses to sensory input, sound, vision, so that's part of that decreased stimulation, but also touching. What may feel like comforting touch to one child could be painful, uncomfortable to them. So we don't want to hold them a lot. We don't want to do a lot of eye contact. And we may need to talk with the family of how much they do, what they like and how much of it they like. These kids tend to have very particular eating patterns. They may only eat orange foods, or they may only eat 5 things and that is it. And if you give them other things, they just won't eat. So they're very picky eaters typically. And they're very slow to transition to new situations, new places, new people. You want to go slow on introducing that. Communication, one thing they can't do is abstract thought. So being brief and being concrete. These are the sort of kids that, some of just the things we say that we don't realize. You want a hot dog? No, I don't want to eat my pet. They don't understand things that are, abstract, or some of that just is kind of normal English language to us, but they'll take it very literally and not understand what we're saying. So be brief and be concrete, and really support the family too. Okay, we're switching now to attention deficit with hyperactivity. This is chapter 17, and you can see the pages there. So what is ADHD? Well, developmentally inappropriate degree of inattention, impulsivity, and hyperactivity. And they typically have all 3 of those, where they can't pay attention. And actually, it's not so much that they can't pay attention to one thing, it's that they pay attention to everything. They can't focus on the teacher talking because they're hearing the clock tick, they're hearing the shoe scuff, they're seeing the girl twirl her hair. They're paying attention to everything, and they can't get rid of those other inputs and focus on just the one thing they should be focusing on. They're incredibly impulsive. They do things before they think. If you ask them why they did it, they don't know why they did it. They did it before they thought about it. So impulsiveness, and that's the one that tends to get them in trouble with their peers, because they're frustrated, so they swing and hit somebody, and they feel bad afterwards, but they did it before they thought about it. And then hyperactivity is not a requirement to go with it, but often is. And actually, boys have the hyperactivity more often than girls. Girls, we often just have the inattention, impulsivity. So for diagnosing, kids have to have this before age 7. The symptoms have to be present in at least 2 settings. So you have to see it at home and at school, or wherever, at least 2 settings. And they have to interfere with the child's life. Some kids are kind of hyperactive and distractible, but they do well in life. So it's not considered ADHD unless it interferes with your life. So it has to interfere with their written and adaptive skills, social status, or self-esteem. Now this is different than learning disabilities. Learning disability, you have a significant disability in the acquisition and use of a specific thing, reading, writing, reasoning, math. And for it to be a learning disability, your aptitude needs to be much higher than your current abilities. So you have the aptitude to learn it, but for some reason you're unable to perform at your ability level in that specific thing. So how do we diagnose ADHD? Well, there's a good box in the book that talks about the different areas they have to have problems in, see problems in those areas, but it basically falls into inattention, hyperactivity, and impulsivity. We, on these kids, will do a comprehensive battery of tests. So we don't do a single test and say, oh, yep, you're positive. We want to do multiple tests and make sure that they're all conclusive. So we look at intelligence tests, hand-eye coordination tests, measure their auditory visual perception, spatial organization, comprehension, and memory. And how do we treat it? Well, our current best treatments really are pharmacologic. We can use psychostimulants, Ritalin and Dexedrine, and these are thought to increase the dopamine and norepinephrine levels that stimulate the inhibitory system of the brain. So it stimulates the part of the brain that helps them not be impulsive, helps them block out those other things that they shouldn't be listening to or paying attention to, so they can focus on one thing. Now some parents will say, I know my kid doesn't have ADHD because they're totally focused when they do video games. Well, occasionally on something they particularly like, they can do that. They do this total over-focus on a single given thing. That might be video games, it might be, I don't know, whatever else kids are into. But because that acts as that same sort of psychostimulant for them. When they aren't doing that thing, then they're all over the place and they can't focus. And some of these kids, we try them on tricyclic antidepressants. And this is thought to block the norepinephrine and serotonin at the nerve endings, which will increase the action of the nerve cells. And then clonidine. Some of the problems, particularly with the psychostimulants, is it decreases their appetite and it makes them unable to sleep. So if we're having a lot of sleep issues, we may need to switch to clonidine. Behavioral therapy, we want to focus on preventing those undesirable behaviors, those things they do before they think. If we can make it habit to not do them, that's what we want to do. And we want to help families to develop appropriate contingency reward systems. So rewarding things they do, even if it's a small step. It may not be where we want to get them to, but they made a small step in the right direction. So don't make unobtainable goals. Make small obtainable goals with rewards as they make those small steps. And then consequences if they don't, but they need to be appropriate consequences, not larger, the crime needs to fit the punishment, not bigger than the punishment. A lot of these parents, this is a different type of parenting and more structured parenting, so they may need help in parenting skills and how to deliver positive reinforcement, how to do those small increments, rewarding them when they reach those desired behaviors, even if it's not all the way to the behavior we want, and how to be age appropriate with their consequences. Environmental manipulation, consistency, both at home, at school, in the hospital. We want to make sure the rules are consistent, schedules are consistent, that their life is consistent even between locations. So highly structured, using organizational charts. You get up at this time of the day, you brush your teeth, and maybe it's a picture chart if it's a younger child and they can't read yet. We can do that with pictures. We want to decrease distractions, especially during schoolwork and homework, because they attend to everything instead of attending to the one thing they're doing. We really want to help these kids be able to focus, because that's what they need to do in order to be